Hello everyone, welcome back to the series of lectures in hematology. Today we will be discussing about plasma cell disorders. So let's begin. So what are plasma cell dyscrasias? Plasma cell dyscrasias are also known as paraproteinemias. Okay, they are also known as paraproteinemias. Okay, so what exactly is this plasma cell disorders? Right, so the plasma cell disorder refers to the expansion of terminally differentiated B cells that secrete monoclonal immunoglobulin called a paraprotein or an M protein. Okay, so let me just repeat that. This is an expansion of a terminally differentiated B cell that secretes a monoclonal immunoglobulin, which is called as a paraprotein or an M protein. Okay, so when you see the autogeny, which means the development of B cell. So once the B cell is formed, this B cell, which is usually a naive B cell, becomes a mature B cell, and then this forms memory B cell and a plasma cell. Okay, and how is the plasma cell identified? It is characterized by an elongated shape with the nucleus which has a spoke wheel pattern. It has a spoke wheel pattern, and the main function of these plasma cells is the production of immunoglobulins. Right, so this much we are aware of. So when this terminally differentiated B cell is usually associated with increased immunoglobulin production. So due to some mutation, the terminally differentiated B cells, which are the plasma cells, become hyperactive when they become hypersecretory, and there is increased production of a monoclonal immunoglobulin. What do you mean by that? That means they are all originating from the same plasma cell or the same clone. So there is an undifferentiated, unchecked proliferation of these plasma cells resulting in the production of immunoglobulins, and these are monoclonal in nature, and this is what we call as the paraprotein or the M protein. Okay, so this is the basic origin of a plasma cell dyscrasia. So when you do the immunophenotyping, what are the CD markers that you will identify? You will have to identify the plasma cell markers, which include CD38 and CD138. So all of these neoplasms will have a CD38 and a CD138 positivity. So what are the group of disorders which are classified under plasma cell dyscrasias? So the most common and the most famous is the multiple myeloma. Okay, this is the multiple myeloma. Apart from that, we have the AL amyloidosis, and then we have heavy chain disease. Okay, so we have multiple myeloma, AL amyloidosis and heavy chain disease. Okay, so what do you mean by this kind of heavy chain, light chain? What are these terms? So when you have a plasma cell, it has eccentric nucleus. These are going to produce immunoglobulins or antibodies. The antibodies we know are IgM, which is usually a pentamer. Then we have IgG, IgA, right? So IgM, IgG, IgA, IgD, these are the different immunoglobulins. Now if you just try and recollect from your basic immunology classes, we know that each antibody usually has 2 heavy chains and 2 light chains, right? It has 2 heavy chains and 2 light chains, and these light chains, okay, can be of the kappa or lambda type, right? So these light chains can be of the kappa or lambda type. So when there is a clonal proliferation of these immunoglobulins, predominantly in multiple myeloma, you find clonal proliferation of light chains. There is a clonal proliferation of light chains. If there is a clonal proliferation of heavy chains, then this is separately called as heavy chain disease. So in multiple myeloma, what are you going to expect? So if this is the structure and these are the light chains which are going to be more in number, so there is excess production of these light chains. Alright, so this is very, very clear. So these are the subtypes of your plasma cell dyscrasia: multiple myeloma, AL amyloidosis and heavy chain disease. So before we try and understand what is the definition of multiple myeloma, we also should know certain other terms which basically come as precursors to multiple myeloma. So what is the criteria? The criteria is called as the Revised International Myeloma Working Group criteria. Okay, Revised International Myeloma Working Group criteria. Okay, so this recognizes that there are certain precursor events which happen before a florid multiple myeloma happens. Okay, so the plasma cell dyscrasia, before it comes into a full-blown multiple myeloma, it goes through certain stages that we can see, and those are monoclonal gammopathy of undetermined significance, or it is also called as MGUS. Okay, MGUS, and then we have a smoldering myeloma, and then it comes to the multiple myeloma. So how exactly do you differentiate between all of this? So monoclonal gammopathy of undetermined significance basically states that this happens when the serum M protein, there is an elevation, but the elevation is less than 30 milligram per deciliter. Okay, right? And what about the bone marrow plasma cell percentage? Bone marrow plasma cell percentage is less than 10%. And is there any evidence of myeloma defining events? What are myeloma defining events? This is also called as the CRAB criteria, which is hypercalcemia, renal failure, anemia and bony pains. Okay, so if there is evidence of any of that, that is what we call as a myeloma defining event. So in monoclonal gammopathy of undetermined significance, you do find certain elevation of monoclonal cells, but the protein total levels in the serum of monoclonal protein, it is less than 30. In the marrow, the percentage of plasma cells is less than 10%, and there is no evidence of any myeloma defining events, and hence you will not call it as a multiple myeloma, you call it as a monoclonal gammopathy of undetermined significance. Then what is smoldering myeloma? So the next stage is MGUS, goes on to smoldering myeloma, goes on to multiple myeloma. So the next stage is, in smoldering myeloma, you do have the serum M protein more than 30 gram per liter, and the marrow plasma cells, if you do a bone marrow, the plasma cells are around 10 to 60%, and very importantly, again you don't have myeloma defining event. What is a myeloma defining event? It is the CRAB features, hypercalcemia, renal failure, anemia and bone pain. Multiple myeloma, how do you define it? Yes, all the three are there, and definitely there are myeloma defining events, right? So we will be looking at these definitions once. So what is the risk of transformation of an MGUS into a multiple myeloma? Usually the risk is around 5% per year. Okay, so if there is a patient whom you are diagnosing with an MGUS, basically he has to be just monitored every year for the progression to multiple myeloma, right? So what is plasma cell leukemia? So all this while what we were discussing is plasma cell dyscrasias. The blood does not show any evidence of raised or increase in the plasma cell percentages. Okay, so plasma cell leukemia is a type of plasma cell dyscrasia where there is evidence of plasma cells in the peripheral smear as well. So let us look at the definitions once again. So what is MGUS? So here the serum monoclonal protein is less than 30 gram per liter, clonal bone marrow plasma cells is less than 10%, and there is no myeloma defining event. Smoldering multiple myeloma is also called as asymptomatic myeloma because there are no myeloma defining events, but the monoclonal proteins are more than 30 and the bone marrow plasma cells are more than 10%. So when we speak about symptomatic multiple myeloma, it is defined by the myeloma defining events, which is evidence of one or more of these symptoms, which is CRAB. Okay, so what are the CRAB features? Hypercalcemia of more than 1 milligram per deciliter, higher than the upper limit. Then renal insufficiency, creatinine more than 2. Anemia where the hemoglobin is less than 10. Then bony lesions, predominantly it causes osteolytic bony lesions on a skeletal radiography CT or a PET CT, and any one or more of the following biomarkers of malignancy where the clonal bone marrow plasma cell percentage is more than 60% and involved to uninvolved light chain ratio, right? So, the free light chain ratio is more than 100 and more than one focal lesion on MR. So, this is about the CRAB criteria and how do you define symptomatic multiple myeloma. Okay, so remember, CRAB stands for hypercalcemia, renal failure, anemia, bony lesions and bony pains. So, when we speak about multiple myeloma, it's characterized by the presence of what we call as an M protein, which is a monoclonal protein. Okay, so there is evidence of an M protein, which is a monoclonal protein, and the levels in the serum are more than 30 gram per liter, and the bone marrow plasma cell percentage is more than 60%. Fine. Okay. And this myeloma defining events just now we have gone through, remember, CRAB. So, what is the age of presentation of multiple myeloma? It is usually in the 6th or the 7th decade. And male to female ratio is 1.4:1. It is more common in the black race. And we have never found any significant risk factors, and the only risk factor which has been postulated is an increased BMI. Fine. Now, let us understand the pathogenesis of multiple myeloma. So, usually the B lymphocyte is the one which basically terminally differentiates, right, into the plasma cells. So, whenever there is an IGH translocation at chromosome number 14 or hyperdiploidy, so these are the only risk factors or the genetic mutations which have been found to be associated with the B lymphocyte development into an MGUS. Now, MGUS is converted into multiple myeloma at a rate of around 5% per year, and if this has to happen, then there are certain other mutations which contribute to it, including a RAS or a C-MYC abnormality, increased interleukin 6, the loss of the tumor suppressor gene which is P53, activation of RAS or NF kappa beta activation. So, these are some of the mutations which are associated with an increased risk of transformation of MGUS into multiple myeloma. Fine. So, let us understand the different clinical presentations, right? So, the most common clinical presentation is anemia, which is seen in up to 70% of the individuals with multiple myeloma, and it is usually a normocytic normochromic blood picture. Okay, so anemia is the most common clinical presentation, then followed by bony pains, right? So, why are there bony pains? Because there is osteolytic lesions, and these osteolytic lesions can also predispose to fractures which are pathological fractures. They can be pathological fractures, and this causes severe bony pains. Okay, so this bony pains is the second most common clinical presentation which is seen in up to 50% of the individuals. Then, renal manifestations are seen in up to 20% of the individuals. So, what are the different renal manifestations of multiple myeloma? One, there can be AKI. Why is there AKI? Mainly because multiple myeloma can be associated with a very important electrolyte abnormality, which is hypercalcemia, and hypercalcemia can result in pre-renal AKI. Okay, so that is one of the renal manifestations. Secondly, many of these myeloma patients would have been on NSAIDs on and off in view of the chronic bony pains, right? So, myeloma patients can have NSAID induced nephropathy as a risk factor for the renal failure in multiple myeloma. Then, third, multiple myeloma is associated with the formation of large number of immunoglobulins which can result in obstruction of the tubules. So, this can result in tubular obstruction, and this is what we call as the myeloma cast disease. Okay. So, tubular obstruction in the kidney secondary to myeloma cast is another cause for renal failure in multiple myeloma. So, we have learnt three mechanisms: pre-renal AKI because of hypercalcemia, NSAID-induced nephropathy, tubular obstruction due to myeloma cast, which is called as myeloma cast nephropathy. And the fourth mechanism is that multiple myeloma can also be associated with amyloidosis, and hence you can have nephrotic range proteinuria as well. Okay, you can have nephrotic range proteinuria as well. So, these are the different mechanisms by which myeloma can affect the kidney. Then you can have hypercalcemia, which is again seen in up to 28% of the individuals. That's the reason why you remember CRAB, which is hypercalcemia, renal involvement, anemia, bony pains, and we have understood the different mechanisms of kidney involvement in multiple myeloma. Fine. Then, can multiple myeloma involve the other systems apart from what is mentioned as cardinal systems? Yes, there can be neurologic involvement. How is the neurologic involvement present? So, neurologic involvement can happen especially if there is a hypergammaglobulinemia and there is a hyperviscosity, then this can cause CNS side effects. It can cause CNS side effects. Also, multiple myeloma can present in the form of local lesions. Local lesions where the myeloma cells organize and grow in the form of tumor-like lesions, what we call as plasmacytomas. Now, these plasmacytomas are very frequently found in the skull, in the vertebrae. They can also be found in the spine, and once found in the spine, they can cause compressive myelopathy. So, plasmacytoma can result in compressive myelopathy. Okay, right? Apart from this, there can be pathological fractures in the spine, and again this also can result in compressive myelopathy, weakness in the lower limbs, paraparesis. Okay, then can multiple myeloma cause peripheral neuropathy? Yes, it is associated with peripheral neuropathy, significantly associated with the Poems syndrome. Okay, Poems syndrome is an important syndrome. We will be discussing that again. Okay, alright. Also, myeloma patients are prone to recurrent infections. This is mainly because their immunity is low, because the gamma globulins are lower and you have a monoclonal protein which is overtaking that, and hence the immunity drops and they are prone to recurrent infections. Okay, so this is about the various clinical manifestations which you can see in multiple myeloma. Now let us move on to the diagnosis. So how do you diagnose? So the basic underlying test that has to be done for the diagnosis of multiple myeloma is the detection of a monoclonal protein. So how do you detect a monoclonal protein? So the first step is the serum protein electrophoresis, SPEP, serum protein electrophoresis, right? So normally what happens is when you do a serum protein electrophoresis, what are the different proteins which you can see? You can find albumin, alpha-1, alpha-2, beta-globulin and gamma-globulins, and usually there is no spike because all the proteins are distributed in an equal manner. But when there is a para-protein, there is excessive production of one particular monoclonal protein, there is going to be a spike in this gamma region, and this is what we call as the M spike, and this appearance is also called as the church spire appearance, which is seen in your SPEP, serum protein electrophoresis, suggestive of a plasma cell disorder. But the problem with an SPEP is that this spike is always not specific for multiple myeloma, and the sensitivity is also low. That is the reason why you have to combine this SPEP with an immunofixation. So when you combine the SPEP with an immunofixation, then the sensitivity increases to more than 90%. Okay, so sensitivity increases to more than 90%. So in immunofixation, what we do is we try to discern out what type of the immunoglobulins are produced. Is it an IgG phenotype, IgA, IgM, and what type of light chains? Is it kappa or a lambda? So you can see that here it is picking up IgG antibody along with lambda light chain, right? So this is a lambda multiple myeloma. So when you do an SPEP with an immunofixation, it increases the sensitivity to more than 90%, and the last step would be to do an SPEP with an immunofixation along with the free light chain levels, which increases the sensitivity to more than 98%. And why do you need this free light chain assay? FLC stands for free light chain assay. So why do you need this free light chain assay? The reason being, free light chain assay basically helps in identifying those types of myelomas where only light chain production is higher, right? So you can find out that the more number of free light chains are produced when we do a serum free light chain assay. Okay. So this is about the various tests used in the diagnosis of multiple myeloma. It includes SPEP and immunofixation, SPEP immunofixation along with free light chain assay, right? So what is the serum free light chain assay? It measures the kappa or the lambda immunoglobulins that are unbound to the heavy chains, right? So there might be types of myelomas which only produce these free light chains which are unbound, and that can be detected only by the SFLC, right? So light chain myelomas in fact account for 20% of the myelomas, right? So in those cases SPEP may be negative and it may only be the free light chain assay which is detecting them. So let us understand a few more terms, which is non-secretory myeloma. So you have to understand that what if all these tests come negative, then is there a component called non-secretory myeloma? The answer is yes. So in a non-secretory myeloma, there is no M protein in the serum or urine and with the immunofixation. But when you do a bone marrow, there is clonal plasmacytosis more than 10% or evidence of plasmacytoma may be present. Okay, so SPEP immunofixation may be negative and the plasmacytosis in the bone marrow is present to more than 10%, and myeloma related organ damage will be there. So this is a non-secretory myeloma. Then what is a solitary plasmacytoma? This is a biopsy proven solitary lesion of the bone or soft tissue with the evidence of a clonal plasma cell. So the multiplying plasma cells go and deposit in the bone or in the soft tissue and become a tumor-like lesion which we call as a plasmacytoma. So in a solitary plasmacytoma, there is a normal bone marrow, but many a times multiple myeloma can have evidence of myeloma in the bone marrow as well as evidence of a plasmacytoma. Okay, and usually in a solitary plasmacytoma, there is no evidence of end organ damage. So there is no Crab features, no Crab. Then what is this Poems syndrome? Poems syndrome is what we were discussing when we spoke about the clinical manifestations in myeloma. It is characterized by polyneuropathy, monoclonal plasma cell disorder, and any one of the following. So endocrinopathy can be there, and sclerotic bone lesions, Castleman's disease, elevated levels of VEGF, and organomegaly, splenomegaly, hepatomegaly, lymphadenopathy. Endocrinopathy is what is the E of Poems, which includes adrenal, thyroid, pituitary, parathyroid or pancreatic dysfunction, along with skin changes like hyperpigmentation, hypertrichosis, plethora, hemangiomas, acrocyanosis, and associated thrombocytosis or papilledema can also be there. So this is a very strange and different syndrome which can be found in association with multiple myeloma, which is Poems syndrome, which comprises of polyneuropathy, organomegaly, endocrinopathy, myeloma and skin changes. Okay, so this is about the other definitions which we have to be aware of, right? Now, apart from all of these testing, what will you find on your basic lab work, right? So in the CBC, you will definitely find evidence of anemia. Then one very important point is there are very few conditions where the ESR is usually more than 100. One of it is multiple myeloma, other being certain immunological conditions like giant cell arthritis, right? So every time you see anemia with an extremely elevated ESR more than 100, think of myeloma, right? Peripheral smear will show the presence of Rouleaux formation, and in the urine you can find evidence of these monoclonal proteins, which is called as the Bence Jones proteinuria. You may find evidence of Bence Jones proteinuria in the urines, but nowadays this test is not being done. Then because of this M spike, the total protein will be elevated. And definitely you have to do skeletal survey. So skeletal survey can be done with the help of a bone scan, it can be done with the help of X-rays, it can be done with the help of a low dose CT or PET CT. So the aim of this skeletal survey is to find out where all these lesions are present and if they are causing compression or not, and so on and so forth. So these are the various other abnormalities which you can expect. Then on the bone marrow, what are the different things that you will expect to see? So you will find clonal bone marrow plasma cells more than 10%. Very, very important. You find the evidence of plasma cells more than 10%. Okay. Now, apart from that, there are certain features which you have to remember, certain types of cells. So, right. So, one is the presence of something called as MOT cells, right. So, within the plasma cell, you may find eosinophilic inclusions. Within the plasma cell, you may find the evidence of eosinophilic inclusions, which are basically the precipitated immunoglobulins, and this is what we call as the MOT cell. So, can you see here this kind of vacuolated appearance, and this is what we call as the MOT cell. Now, when multiple MOT cells are put together, these are what we call as the Russell bodies. So, this is a MOT cell. When multiple MOT cells are together, you may find evidence of these Russell bodies. And you may also find certain other cells which are called as flame cells. Can you see here the flame shaped cells, right? So, MOT cells, flame cells, Russell bodies, all of these can be found in the bone marrow examination in multiple myeloma. Then if you do immunohistochemistry, the CD markers which will be positive is CD38, 138, CD56. Okay, so this is about the bone marrow examination, right? So we had spoken about the skeletal survey. So this is the X-ray which can be a spotter which shows the multiple lytic lesions which are found in the skull. So we have to, for any malignancy, do a risk stratification, and we should know certain standard risk and high risk cytogenetic abnormalities, because the treatment will vary according to this. So remember, in multiple myeloma, standard risks include trisomies, translocation 1114 and 614. So if you remember these, then you can just rule out the others if at all you've asked an MCQ on that. So high risk includes 17p deletion, translocation 4, 14, 14, 16, 14, 20. Right? So this is the standard risk, translocation 1114, translocation 614. Okay? Fine. So how do you treat? So how do you treat multiple myeloma if it is a standard risk patient? If it is a standard risk patient, we do something called as the DRVD regimen, which comprises of Daratumumab, Bortezomib, Lenalidomide and dexamethasone. Daratumumab, Bortezomib, Lenalidomide and dexamethasone. And the other regimens which can be used includes the RVD, where you have only Bortezomib, Lenalidomide, dexamethasone, and DRD regimens. Okay. Then VCD comprises of Bortezomib, cyclophosphamide and dexamethasone. So this Bortezomib, cyclophosphamide, dexamethasone can also be used. So these are usually 3 to 6 cycles and followed by a consolidation therapy with hematopoietic stem cell transplant. In high risk individuals, we do not prefer any 3-drug regimen, so it's not the RVD regimen. It is usually a 4-drug regimen. And what is the 4-drug regimen that we use? We use an ISA-RVD regimen. Okay. So this is isatuximab, which is a monoclonal antibody against CD38. Okay. So isatuximab along with RVD, which is your Bortezomib, dexamethasone and lenalidomide. 12 cycles followed by maintenance with carfilzomib and lenalidomide is what we use for high risk multiple myeloma. And hematopoietic stem cell transplant can be done only in eligible patients. Okay. So this is about the management clinical features of multiple myeloma. Thank you.